All right, we're going to be talking about metabolic syndrome today. You might also have heard the term insulin resistance syndrome or syndrome X. Metabolic syndrome is technically defined as the co-occurrence of metabolic risk factors for both type 2 diabetes and cardiovascular disease. So the reason why it's important is because it's setting the stage for suspicion of the subsequent development of these two high morbidity and high mortality rate disease states. Okay. Currently, there is no technical definition for metabolic syndrome in children, even though children and adolescents can develop it. Because of the varying definitions, it's hindered the development of a consensus. So I'm just putting that out there. And in fact, the ADA, the American Diabetes Association, and the European Association for the Study of Diabetes, EASD, published a joint statement raising questions about whether the components of metabolic syndrome, as defined here, actually warrant a classification as a true syndrome. And this is due to the difficulty comparing data between studies, okay? Many utilize separate criteria. So there are multiple definitions for metabolic syndrome. So for the purposes of this lecture, I'm using UpToDate because they, as their name says, they're usually the most current resource. So UpToDate uses the National Cholesterol Education Program, NCEP Adult Treatment Panel, ATP3, as the most widely used definition. So the diagnosis is confirmed with the presence of any three qualifying diagnoses, okay? So as you can see, increased waist circumference, elevated blood pressure, hypertriglyceridemia, low HDL, or elevated fasting glucose, okay? So the bottom line is that the weakness of the general construct of metabolic syndrome, or the idea of it, is that the treatment is honestly no different than the treatment for each of its own components, okay? So the goal is to treat the individual risk factors, and everyone's going to start with the first line treatment, just therapeutic lifestyle changes and weight management, okay? It's used to predict the risk factors of type 2 diabetes and cardiovascular disease. So everyone, including the defining organizations or powers that be, agrees that clustering risk factors for diabetes and cardiovascular is a real phenomenon. But I also can see that, a patient, what do they gain from actually making and confirming the diagnosis with the syndrome if you're taking good care of the underlying risk factors or disease states? Yes, it's predictive, but what is its value? Okay, it's a very good question. And potentially you could actually cause some harm in your patient by officially making this a diagnosis. Just keep this in the back of your mind. Financially, maybe by documenting this, right? So you may hinder their ability to obtain life insurance, or this diagnosis could increase the cost of insurance when you're going to be treating the individual risk factors or disease states per guidelines anyway, right? So just food for thought. I also think some of this is going to change over the next few years. So because there's not a general consensus, okay? So etiology, again, as we saw, there's a number of factors. Central obesity or excess visceral adipose. So you don't necessarily have to be obese. You can be thin and have extra visceral adipose, okay? But central obesity seems to be the common etiology. The other is insulin resistance, and then there's contributing factors. Let's not forget about endocrine states. So I will say that the NHANES criteria has added their own etiology. So they are saying, in addition to age, race, and weight, other factors carry an increased risk of metabolic syndrome. So as you can see, the list here: smoking, high carb diets, low socioeconomic status, actually no ETOH consumption period, which is interesting. I'm sure excessive, soft drink consumption increases, sugary drinks increase your risk factors. And I'll also note that in the Framingham Heart Study, soft drinks and sugar-sweetened beverages, so your diet beverages included, the consumption of these are associated with an increased risk of developing adverse metabolic traits and metabolic syndrome. So that has been shown. There's also contributing to this can be the use of atypical antipsychotics, and we talk about that in a separate lecture, but especially clozapine can put people at risk for obesity and metabolic syndrome. So let's talk about a little bit of the pathophysiology of the disease. This is a very busy slide, but I just want to show you that the bottom line is that due to the intra-abdominal and visceral adipose tissue, there are few things that happen that contribute to the disease. So there are, because of the abdominal obesity, we develop the resistance to the effects of insulin on our peripheral glucose and fatty acid utilization. So this leads to type 2 diabetes, okay? Again, you don't necessarily have to have obesity, but having that kind of central truncal, kind of apple body, if you will, can contribute. This leads to your increase in your non-esterified fatty acids, okay? This released from adipose, and it accumulates somewhere else. So think liver, fatty liver, and your muscle. So you can have sarcopenic obesity. This leads to insulin resistance. So now, in the setting of insulin resistance, we have associated hyperinsulinemia. So this is actually a high insulin, hyperglycemic state. And we have less adipocyte cytokines or adipokines. And these are protective against inflammation, right? So with less things that prevent inflammation, we now have damage. So microvascular damage results in endothelial dysfunction. We end up having atherosclerotic disease. This leads to vascular resistance, vessel wall inflammation. Remember, obesity is an inflammatory state. This subsequently results in peripheral vascular disease, left ventricular hypertrophy. Remember the whole RAS system, ischemic heart disease, et cetera, et cetera. Again, and the lack of these inflammatory fighting cytokines is a real problem. So basically, all these things lead to vascular inflammation, promotes cardiovascular disease particularly, okay, and then, of course, diabetes. There are a lot of associated conditions, okay, and all these pretty much make sense, okay. Truncal obesity, we have high triglycerides. This can result in gallstones. If you think about all these endocrine lectures put together, we talk about hypertriglyceridemia, we talk about thyroid hormone issues, cardiovascular problems, our vitamin D, our parathyroid function, thyroid function, all of these things are connected, right? Our body is one big machine, and it needs all the parts working. So disease states like PCOS, sleep apnea, all of these things can be associated with metabolic syndrome, and vice versa. They're all related. So our usual approach to making the diagnosis of metabolic syndrome is pretty straightforward. We're going to get their vital signs, establish those criteria. We are really good clinicians, so we want to take in consideration symptoms, look at the review system sheet, folks. I don't think my prior providers ever do. Sometimes I'll throw something in there just as a test, but we need to look at family history. Do they have men's type 2? Do they have genetic disorders, history of hypertriglyceridemia syndromes and things like that? Listen to your patient. They'll tell you it's wrong. So do they have dyspnea on exertion? They're having some angina or anginal equivalents? Do they have some new swelling, pitting edema? Are they having polyuria, polydipsia, signs of diabetes? Are they hirsute with irregular periods? These are all risk factors, okay? So also taking in that very comprehensive lifestyle history. And then we will use our we'll use our cardiovascular risk assessment tool, right? Our ASCVD tool. So again, because we're awesome clinicians, we're going to do a thorough physical exam, head to toe. We're going to note the waist circumference. We're also going to be looking for other exam findings suggestive of insulin resistance or other cardiovascular disease. Okay, so increased waist circumference. Do they have peripheral neuropathy? Do they have retinopathy? Do they have acanthosis nigrans, right? That hyperpigmentation. Do they have bruits? Do they have dyslipidemia? And do they have those deposits of triglycerides, right? Those xanthomas. And do they have bruits? Not only carotid, but don't forget about your abdominal and renal bruits too. I like these pictures. They are from Adam. Okay, in terms of diagnosis, again, we're going to look if they meet their criteria, but we're actually screening for the associated conditions because that's the entire purpose of the metabolic syndrome diagnosis, right? So pick up on well-known associated conditions and risks. Every single patient who has or is suspected of having metabolic syndrome needs to be screened. Even if they are on a statin, a lipid panel should be done on everyone, okay, regardless of length or dose of current statin therapy. If they're on metformin, we're still going to check an A1C, and then we're going to obtain labs according to your level of suspicion, right? So if they have a full thyroid on palpation or strong family history of hypothyroid disease or Hashimoto's, or if they had peri or postpartum thyrotoxicosis or hypothyroid, even if it was temporary, we're going to consider a TSH with a reflex T4, okay? In men with low libido or energy, we want to check testosterone. Consider vitamin D levels, parathyroid hormones, if they have risk factors or sedentary lifestyles. They're indoors most of the time. Check a urine protein in your diabetic patients. Make sure they're not having renal dysfunction. They're not having proteinuria. And do screen LFTs, especially because we want to, if they're elevated, then obtain a liver ultrasound to screen for fatty liver disease, okay? Also, do they have a habitus that is consistent with OSA? So all your further studies are going to be based on your suspicion, okay? So if you hear a carotid bruit, you're going to be getting Dopplers, carotid Dopplers. If they are having signs of angina or a suspected anginal equivalent, you'll obtain an EKG, etc., cardiac stress testing, all of that. I want to note that sometimes we need to assess body composition measurements to assess lean tissue and fat mass. So, you look at your athletes, look at your bodybuilders. They may demonstrate an elevated BMI despite having low body fat. You can appreciate someone when you look at them and they're very muscular, but based on height and weight, they're technically obese, and they're going to take offense to that because they work out every day, right? They have more muscle mass. So actually the preferred method is not calipers, which, pinches those the excess skin on elbows and knees and things like that. It's actually a DEXA scan. So DEXA is currently considered the preferred method to determine body composition when BMI and your clinical level of adipose tissue are just discordant, okay? will note, sometimes I'll tell people, I'm like, hey, if you go tour some gyms, Lifetime Fitness, LA Fitness, some of those, they might actually do a free body composition test with their tours. So it's a good way to get a screen. There's also community screenings that occur frequently. You just have to do some local research so you can help your patients get those resources. So don't forget there can be sarcopenic obesity, and these are your elderly people that may demonstrate a normal BMI by screening, but they're actually obese because they have less muscle mass. So let's look at our approach to treatment. Our primary therapeutic goal is going to prevent or reduce obesity and risk factors. Okay, so aggressive lifestyle modification. That's our first line all the time, unless they've got a super high ASCVD risk score, in which we're going to start with probably lifestyle plus medication at the same time, or they've got uncontrolled diabetes, hypertension, etc. Right? So there is evidence that aggressive lifestyle modification, which is diet and exercise, can work and be clinically effective in more than a 7% weight loss and or significant dietary carb restriction. So get rid of the sugars, desserts, breads, stick to your legumes, things like that for your carbs. It can actually improve and even reverse the risk factors associated with metabolic syndrome. Okay, so there are some recommendations, I should say, to consider preventative medications. So, consider metformin. That's very preventative on multiple levels. And consider aspirin with higher risk factors, but you'll utilize your American Heart Association and USPSTF about risk benefits, right? We no longer just give baby aspirin to everyone, because if they don't have risk factors, it could actually cause harm, right? So individualize your care always, utilize your guidelines, okay? This is redundant. I feel like we're going to individualize our care. We're going to utilize aggressive treatment. For those risk factors, we're incorporating lifestyle modification, which we all know is stop smoking, excess alcohol intake, avoid sugar-sweetened beverages. And I do want to note that actually non-sugar-based, so sweeteners, artificial sweeteners, they can actually alter sweet taste receptors and gut hormone secretion and promote gut microbiome imbalance and insulin resistance, okay? And some new studies that came out actually reveal that erythritol is, if you start looking at your packaging and your artificial sweeteners and your diet labeled drinks, those are all many of them have erythritol in them, even things that are labeled monk fruit sweetener. Look at the back. I found several with erythritol in it, and certain drinks. So that has been recently shown this year to be associated, that sweetener in particular, with an increased risk of heart attack and stroke, okay? However, I'll also say is, and then as recently as January and March of 2023, national organizations like the National Cancer Institute and the NIH, they deny that studies, they're saying that there's no association between artificial sweeteners and cancer. But it's interesting that there's a significant uptrend in colon cancer also announced in 2023. So I wouldn't be surprised if we later found a link with colon cancer, okay? Younger and younger people are getting it, and we have reduced the age for screening colon cancer. So I feel like there's probably a coexistence, the people seeking out these diet labeled drinks and foods, the sugar-free stuff, because their doctors told them, their PA told them, their NP told them to stay away from sugar. So naturally, maybe these are marketed towards people that already have these cardiovascular risk factors. So there could be a component of bias with that study on erythritol, but also common sense seems to say it's not natural. Okay. So promote healthy diets. If a patient can't tolerate intermittent fasting, don't consider it. Utilize what they can adhere to. Okay. Always increase your colorful vegetables and sleep patterns. And as much as the semaglutide, Ozempic, Wegovy, all the marketing for the weight loss associated with medications typically used for type 2 diabetes are increasing in popularity and showing results comparative to bariatric surgery. The current literature, okay, as of 2023, still maintains that bariatric surgery is first line after failure of lifestyle modifications in people with BMIs over 40, okay, or BMIs over 35 with comorbid conditions. I think this could probably change here in the near future. So again, redundant slide. I just wanted to put that out here. We want to focus on physical activity, obesity decrease. The cornerstone is going to be lifestyle change. All right. Then we will consider alternative medications. We want to treat the underlying causes, in which you'll refer to the guidelines for treatment of all those underlying or comorbid conditions. Okay. I also want to note physical activity. It's not going to be doable to take somebody who's completely sedentary and say, you need to work out for 60 minutes a day. I personally won't do it, right? We work and it's not always doable, but cumulative exercise actually still shows that it works. So cumulative exercise over time in the day, it will contribute to that benefit. So if they can get out for a 5-minute walk, tell them to park in the back of the Walmart parking lot and walk in. They're having to walk around the store, they're walking out. That will accumulate during the day. Maybe they could do a few squats and lunges, take a walk here and there. Even in the house, you do some light aerobic exercises and stretches. It will add up to an hour through the day. So it doesn't have to be done all at once. As far as pediatric considerations, I already mentioned that metabolic syndrome occurs in children and adolescents, but there's no consensus for the definition. Of course, there are going to be risk factors similar to adult risk factors, including poor health habits and hereditary issues. There is ethnicity counts towards risk factors, and maternal gestational diabetes and low birth weight can place them at risk as well. The NHANES 3 survey estimates about the prevalence to be about 9% of American children. It's pretty high. So again, in children, we have similar racial and ethnic distributions of obesity, similar to adults. Mexican Americans are at the highest risk for metabolic syndrome and obesity, followed by non-Hispanic whites, then non-Hispanic Blacks, and then actually Native Americans are thought to be greatest risk of pediatric metabolic syndrome and obesity. It's almost 20%. That's high. So again, we're going to try to promote healthy lifestyle habits and modifications that involve the whole family, because they are going to follow their parents' patterns, right? So we need to refer if, perhaps if we have the opportunity to have a dietitian, that's always really helpful to have a nutritionist weigh in and help your patient maintain a good lifestyle diet. We're going to refer out if their LFTs suggest some liver disease. If we have suspected OSA, they're going to need to be seen by a pulmonologist, potentially get some sleep studies. We also need to weigh in on phenotypes and weight-related mental health concerns. And then again, bariatric surgery is recommended after failure of our conservative management and lifestyle modification. again, we want to follow up. We'll be seeing these people frequently, trying to be encouraging, not dismay people. They don't need to hear every time they see you that they're not doing a good job. So try to pick out the positive changes that they're making, and be their advocate. Okay, we need to monitor, especially because the syndrome puts them at risk. We need to continue to monitor their waist circumference and their weight, BMIs, their lipids, and their glucose levels. Okay. Do also note when they're doing a really great job and they've lost a lot of weight, they might actually swing the other way and end up with hypotension, or they might end up with hypoglycemia. So you'll need to pull back on their medications because they're doing awesome, right? That's the point. That should do it. The resources I use today, UpToDate for most of my material. Also, a nice easy read is usually the Merck Manual Professional Edition. It's free online if you don't have access to UpToDate. And this is a great podcast resource. Is PA Carly Burridge. She started, it's called Gaining Health Podcast. There's the link to it, and she has a lot of really interesting lectures. She has evidence. She breaks down some newest and greatest evidence-based medicine. She also looks at things on a metabolic and whole patient level. So definitely check that out. Have a great day.